today. But still, let us continue our work. We still have a whole session dedicated to spinal pathology ahead of us. As Dr. Pirogov said, first organization, then treatment. Actually, it would be logical to have such a complex session in the morning, but it's an issue of organization, and we are going to deal with what we actually have. So let us start. The session will be moderated by Dmitry together with me. We are going to speak about the organization and principles of treatment of patients in a private clinic, at a university hospital. I think it's very interesting.
This will be more of a fun presentation than a scientific one, but I'll try to share a small snapshot of a complex system in the United States. So we're going to pretend, for the purposes of the presentation, as though there's two main categories in the United States. One would be academic practice, and one would be private practice. And I'm just going to kind of try to share the pros and the cons, the burdens of these two groups of doctors as they try to do their work. Is there a clicker somewhere? Is there a clicker? Here. Ah. Okay, so first, for the doctors that work in the academic environment, most of our academic environments, just like those in Russia, are larger. They tend to be in urban areas. They tend to have more specialized treatment. And as far as the employment for the doctors, they tend to be more on an employment model. So the doctor would likely be paid a salary for the work that's done. As far as the nature of the practice, it's one that may grow to have a larger reputation, perhaps a national or even in some cases international reputation. So academic medicine is traditionally said to be based on three major pillars. The first is patient care. Of course, that's always the first of any doctor, but there's two other important things for the doctor that works in academics. He must also be doing research, and it's an important thing because we have this term in our country called publish or perish. And what this means is that for doctors on an academic track, they're expected to have a certain academic production, publications and other academic work, and if they don't reach their goals, then they may have some problems. And then the third issue is going to be teaching. So it's likely that the physician in the academic setting would be involved in teaching different levels of medical education, medical students, and so forth. So again, this is going to be more of an urban type environment. Physicians may be involved in either basic science research or clinical research. I would say more physicians are involved in clinical research, but certainly basic science is very prestigious for those who do it well. As far as it relates to spine surgery, for the types of cases that would likely be done in an academic environment, they would tend to be the more complex cases, possibly using more technology, and likely involving trainees. So there may be residents or fellows involved in the surgery, not unlike here, but as you might imagine, this is not necessarily a recipe for highly efficient cases. This is more of a recipe for more complex type cases. Most doctors would have teaching responsibilities, and these are very important when you are on an academic track and you're trying to advance in your career. they will evaluate your teaching performance and your research performance very much, probably more so than your clinical performance. And so this can lead to some physicians on an academic track that are very successful in their research and their teaching, but you know from working with them you wouldn't necessarily want them doing your surgery because that may be the weaker link in their practice. So what are the challenges of an academic practice? Well, I already mentioned the publish or perish. This can be a very big one early in your career. Once you get past a certain level, they say you have tenure. When you have tenure, then pretty much, you know, you can't be fired. You're in a protected status. But until you get tenure, you're unprotected, and if you don't perform well enough, you can be asked to leave. If you are doing research, funding challenges can be a big issue. There's many sources of funding, but the biggest is in the United States is the National Institute of Health. But the funding from our government to the National Institute of Health has been reduced for the last decade. And so it makes it much more competitive to obtain funding, and this can be a big problem. At bigger institutions, of course, you have bigger political issues, and these can come into play in your career. In general, doctors in this situation, they're going to have reduced income compared to those in private practice, and I'll show some data on that. And you're working in a big, complicated system that's not very efficient, so productivity can be compromised. One study looked at the price of choosing an academic career, and so depending on your specialty, doctors and academics may take anywhere between a 13 and a 60% pay cut compared to their colleagues in private practice. And that's essentially what this article with this graph shows. The yellow is the doctors in academic, and the blue is those in private practice. In addition, there's much less variability. So when you start your career and you have a salary and you are there for 30 years and you're a full professor, the difference between starting and ending is actually much less than it might be in a private environment. Okay, so how about private practice? So in a private practice situation, generally speaking, you may have a more efficient type of setting where maybe you're doing smaller cases but higher volume. Things like case turnover between, if we compare our university hospital, between one case and the next, it could be 1 to 2 hours while they're getting everything ready for the next case. And part of this is due to complexity, and part of it's just due to inefficiency. The same would be completely unacceptable at a private hospital because people would never get anything done. It's safe to say that there's a little more of a generalist approach within your specialty. For instance, if you have an orthopedic background, you might do spine but have some responsibilities taking call for general orthopedics, or if you're a neurosurgeon, you may have some cranial trauma that you have to deal with that may be a little different than your spine practice. A lot of times in private practice as well, you know, you're sort of in part managing a business. It depends on the size of the private practice, but you may have to have responsibilities being a businessman, and many physicians don't have formal training in business, so that can be stressful. Others are naturals, and they're very good at it. One of the advantages that you may have in private practice is you may have a little more flexibility in your schedule. So instead of having everything be dictated by your boss, you are sort of your own boss depending on the size of your practice, or at least you have more input, so you can maybe have more of a role in hobbies or other family responsibilities in some cases. One of the issues in private practice is the trend in our country of consolidation into larger institutions. So a lot of small hospitals are either being purchased by bigger health systems and sort of somehow rolled into the health system, or in some cases they're closing because it's hard to compete, because everything has gotten more and more difficult for the small institutions. There's sort of a third model, which is the model that the practice I work in tries to do, which is sort of this hybrid, a privatemic. So it's a word kind of mixing private practice and academics. They seek to have the best of both, and of course there's compromises in everything, including this model. But They try to have, sophisticated care, teaching, and research like an academic practice, but they try to have an efficient environment and maybe enhanced compensation. So obviously this sounds great. Doesn't always work out that way. But I work in a group that's basically based in an urban environment in the Philadelphia area. It's 268 doctors, so pretty big group. They have 42, if you count all the offices and hospitals and surgery centers and everything, there's 42 different locations that doctors in our group may work. And it's kind of a hub and spoke, meaning that we're centered around a university, Thomas Jefferson University, and that's where complicated stuff tends to be referred to, but there's a lot of work that goes on in the community. So for myself, I work 1 day a week at the university hospital, and we do bigger, more complicated things, and 2 days a week I do surgery at more of a community hospital, so a little bit of a hybrid. So thank you very much for the chance to share a little bit of our experience, and I'll be happy to participate in the discussion.
Есть ли какие-то
Are there any questions right now about the presentation?
very interesting, and now we can compare how it happens in Moscow. Сергей Геннадьевич, можем мы пока
Sergey, may we ask Andrei to make his important presentation first about the subject that he wanted to cover, because he will have to leave us. Yes, I'm sorry, I will have to leave soon, so I will make my presentation now. So, what about Moscow? I'm going to make a brief introduction to that. Indeed, in the 90s, there was Hospital 67, that was a very well-known center. There was also Hospital 19, who dealt with spinal patients, and basically no one wanted to deal with spinal patients because cases were very severe, there were bad sores, and these patients were lying for months. That was an awful situation, and no one wanted to deal with these patients, and only Hospital 67 wanted to help them. And now actually the situation has changed, and there are many hospitals willing to work with such patients. In 1997 we had a lot of severe cases that were not operated in a timely way. Now it's not the case. In Moscow, in July 2019, you can see here the number of our patients. We have more than 700 beds in neurosurgery department. We have 95 beds for neurological ICUs for Moscow, and we have a bit more than 200 of neurosurgeons for Moscow. According to the data of 2017, 87% of Muscovites got treatment in public hospitals and only 13% in private ones. As for the equipment level, it is quite high. It is higher than on average in Russia. We have 2 robots, we have a gamma knife, and overall we have good equipment to provide all the necessary manipulations. We have 15 hospitals that provide treatment to patients with spinal injury, and we are soon going to open yet another hospital. It will be a state-of-the-art hospital with a new neurosurgical department for 30 beds. So we will get 30 additional beds. Here you can see the breakdown of our spinal hospitals, and still we can see that Hospital 67 has most beds. and they are not all occupied, so we will probably reduce their number a little bit and add these beds to the other hospitals that need more of them. As for staff, we still have a small staff shortage, but the situation is not bad overall. As for the dynamics, you see that over the last 14 years, we have an increase in the number of degenerative diseases. We have an increase in the number of acute spinal injuries, and we have more patients with tumors and spondylitis. As for degenerative diseases increase, it is explained by the fact that the population is getting older and we have better diagnosis. Why do we have more spondylitis? Because we provide better surgeries, because the number of patients overall is increasing, and because of better diagnostics. As for inflammatory diseases, before, spondylitis was considered equal to sepsis in treatment, and it was financed as sepsis. But we made a calculation, and we counted that treating spondylitis, treating one patient, will cost 500,000 to 2 million rubles. Fortunately, then the financial quota for such patients increased, and that is why we now treat more cases of spondylitis. Here you can see some statistical data regarding our work. We see an increase in the number of patients and in operations.
That also have increased surgical activity, and mortality rate is declining. Surgical activity regarding spinal pathologies, you can see traumas, spinal traumas is increasing. In the brackets you can see the needs. What about pathology rate? 100,000 people. For 100,000 people, we have surgeries for 900 because maybe we have not only Muscovites, degenerative diseases, nosology 6,300, tumors of spinal cord 125. And in Burdenka, at Burdenka Hospital also they give surgeries like this. And also spine tumors, this is separate. Also in Moscow, and 188, this is surgeons, but also we have conservative treatment. 2,000 dynamic of bed fund of neurosurgery. So we had several hospitals for this, and this is 21% out of all foundation. I will not go into details, but you can see we have less beds. But now spinal center, 67 hospital, treat only spinal pathologists, and hospital of veterans also has 40 beds. And more patients with spinal pathologies without traumas, because they don't have hospital. 15% of bed only spinal pathology. And now look please, 2017 we treated more than 100,000 patients with spinal pathology. Mostly 70% degenerative disease, 19.3 traumas. And if we look in so 14 for the first 14 years, traumas more than by 20%. Now we have an increase of patients with degenerative diseases, degenerative pathologies, and now so I wrote also The first hospital of Pirogov, Konchalovsky Hospital, 7, Yudin Hospital, 12 Hospital, 13 Hospital, Hospital number 13, in the name of Remeshantsov, 33, hospital number 33, and now this is the hospital of Inozemtsev, Vorokhobo, hospital 81, Botkinsky hospital. You can see a lot of pathology. To the left, how many patients, to the right, how many surgeries. So 178 with spinal trauma tumors, 14 came, 11 surgeries, 1,000 of patients. But we had 1/3 of patients have spinal pathologies. We should pay attention to this problem. And among this 10,000, 3/4 had surgeries. So 11,000 patients had surgeries. 2/3 of patients had surgeries on spine. And our goal is to give surgeries to these patients, and tomorrow he should go already to work these patients. That's our goal, main goal. And here, this is the experience of private clinic. Degenerative scoliosis, balance is ruined, adenosis of canal. What so should we do here? Here you can see a 4-part system, quite long-term, short screws. And here you can see the stem to the right. It's shifted. It goes somewhere below. And patient again come to him. They correct treatment. How did they correct? So the stem, they make it a little bit up, lifted this up. Unfortunately, this is Moscow private healthcare center, private hospital. So then the patient came to me. I explained to him. That was the cervical, but this is for free, and maybe he did not like it that it was for free at our hospital, so he went to another hospital which he had to pay for this, and then again he came to us to correct all what is done in the previous one. I offered him to do all this for free, but he didn't want to do this. Then he so then I so you can understand me that that's really horrible. There are so many technologies in Moscow, a lot of specialists, experts. Hospital 68, the Burdenko Institute, Neurology Institute. So we have so many specialists. You can go, and patients, it's okay to have second opinions for the patient, but patients usually sometimes choose quite strange hospitals. And what is the problem today? We have quite a huge flow, many patients, but there is lack of personnel, especially care providers. And we have a lot of written work, paperwork. We lack anesthesiologists. We lack nurses. And also not enough not enough care departments. So the success of treatment, 25%, this is surgery, but 75% this is rehabilitation care and so on. So rehabilitation is extremely important. So two specialists should work with this patient and 3 hours per day. And we need a lot of specialists. Who will pay for this? So care is a problem. Also, we don't sometimes have mattresses which are anti-bed sore. We need to have this like a continuous system, a uniform system, and also we have to buy neurosurgical implants for the departments, and we also should finance this. If there are no implants, we make patients buy this, but now we do this ourselves. Of course, there are 3 or 5 special hospitals, spinal pathologists, 4 hospitals, oncological, specifications, but surgeries should be performed everywhere, or in any other case, some other surgeons can lose their qualifications. So we cannot focus all this only in some very separate hospitals. Thank you very much for attention. And that's the picture from the previous seminar. Thank you, Andrei. Do you have any questions or comments regarding Moscow? So, a lot of information for us on nosology and hospitals, statistical analysis. Also, Andrei spoke about prospects, about the future. Now we know some information about hospitals in Moscow. What about specialization? We have neurosurgical pathology, which is linked with brain pathology, and it also can have a lot of types. For example, vascular pathology, oncological, spinal pathology. So this is one question. So specialization, or there is a neurosurgical department and it should do everything, little by little, or should we really have specialized hospitals? And then inflammatory diseases, it's also relevant for us. There are no any specialized neurosurgical department which could really focus on this inflammatory diseases. But still, we have to manage this. Can you also comment on such things? We have been thinking a lot about it. We had aneurysm, vascular patients. We had 4 hospitals for this, but there are not so many aneurysms. 1 million people, so 600 only patients. So 150 for each hospital. Spinal patients, we have a lot of spinal patients. In 2000, Sklifosovsky Hospital started to do spinal pathology. We covered everything, and hospital number 68 and Sklifosovsky Hospital covered all needs of Moscow. So I could say, okay, I have a lot of surgeries, that's fine, but at that time we started to train people, and of course now we have much more surgeries. We need people, other surgeons, and these hospitals also, so this help should be rendered in all hospitals. But inside of our department we have, for example, 60 people, but we have the group which is focused on vascular pathologies or tumors, it's another group, spinal pathology, another group. So if we have a patient and he has spinal injury, in this case we have a responsible person who makes surgery, this surgeon is on duty and he has another specialization. So, but we can call the necessary surgeon and he can come at any time. So you can see that we have different surgeons, and each surgeon works in his direction, so unfortunately I cannot hear the speaker now. So if we have, if we do spinal pathology, we should do everything about this. If we have complications, we also should tackle them. So if we do traumas, spinal trauma, spinal injuries, we should know this problem. So we should know this problem. Or if you don't know this problem, it's better to stay away from it. Thank you very much. Are there any additional questions? Andrew, I have the following question. Within the last 5-10 years, did something change? If, for example, you have non-specific pathologies, do you have the trend that so how do you treat these conditions in neurosurgical departments? Do you conservative, not specific cystitis, or maybe it's neurosurgeon? Neurosurgery does not have this notion. This is, other types of surgery. So only 10% of all patients out of these patients should go through surgeries. And also, yes, we can do surgeries. This came from tuberculosis surgery. Now we have a thesis from Irkutsk, and in this thesis it's written about this purulency complications. How do you think? What profession? This was surgeon, and surgeon says this is purulency direction. This is our area now. So I say that you can treat this in surgical departments, so not conservative, because surgeons are sure that it's surgical. I would like to speak about assisted, I would like to speak about our attitude to this. This is very homogeneous disease, hemodialysis patients, and I had this patient in the USA. He came to me 2 weeks ago. He had the pain in lumbar area. Neurosurgeons, of course, can recommend something, but then this patient, but a neurosurgical bed costs a lot. We should not give them this bed. That's waste of money, because in today's medicine, modern medicine, we have antibiotics. This patient just can be observed by some other physicians. He has medications. This patient usually is hospitalized. Within 1 week, he has long-term venous pot. Maybe it happens on the 2nd day when he comes to hospital. Then he has 2 antibiotics, oncomycin, for example, or something else. And in 1 week, he is discharged, and twice per day the nurse comes to him, and this is already at home. In 4 weeks he has oral antibiotics, 8 weeks, and that's fine. These patients should not have surgeries. We even don't do disc biopsy. Today, this is not pathology, which is treated in America by neurosurgeons. It is clear that there is the pathology which we can treat conservatively, but there are some indications for surgical treatment. For example, some abscesses with compression, neurological symptoms, violation of some spine parts, and we can see that the process is developing. We should do something here. Where should this patient be operated in big hospital? In which department? There is the department of neurosurgery, traumatology, and orthopedic. Do you have in the USA some separate department where you get the patients with inflammatory and purulence damages of spine and bones? You isolate them from other patients, and how do you do these surgeries? Or if a patient is in one hospital, so the surgery is in this hospital, or is he sent to other hospitals? Because he's a threat to other patients who are so-called clean. Because, for example, you have one surgery room, and I have to make a surgery of osteopamyelitis, and then I cannot have any other surgeries for other customers. What about your center? What about your hospital? How do you do this?
Thank you. We're perhaps a little bit different in the way we're organized than what I've seen in Moscow, in that in our hospital we tend to have what we call a multidisciplinary approach to most of these cases. So if a person had a serious spinal infection at a community hospital, they would very likely be transferred to the university hospitals, more sophisticated, because the private hospital, first of all, doesn't want this case because they're going to lose a lot of money, as you said. So the university hospital tends to be like a backstop. They get all of these types of cases because they're theoretically more difficult. But when they get there, the way they manage it is it normally goes on the service of a so-called hospitalist. A hospitalist is usually a medical doctor that only has a practice taking care of patients in the hospital. They would take care of, for instance, we have hospitalists that take care of spinal patients. There's going to be other hospitalists that might do other specialties. And then the hospitalist is going to consult the surgeons. They're going to consult infectious disease. Maybe they're going to consult nutrition. If there's other medical issues, there could be other medical people consulted. And the surgeon is going to make recommendations just on the basis of whether or not the patient is a surgical candidate or not. Some patients you may be observing for a period of time to see their response to non-surgical care, but it's not going to be on the service of the surgeon. In the case where the patient does require surgery, the patient would go to the operating room, have the operation. They would be on the surgical service just for a short time to deal with any acute post-surgical issues, and then when they're stable, they're going to be transferred back to the hospitalist. And like everything, there's pros and cons, but I think the advantage to this approach is that each person is good at one small piece of the puzzle, and then the hospitalist kind of puts the puzzle together so that hopefully it provides the best outcome to the patient.
Thank you very much. Sergey Gennadievich.
Sergey, what's your case? So first of all, about purulent patients and in general. Thank you very much. Speaking about purulent complications that can be found in particular in our hospital, and I cannot deny that there are some hospitals, be it federal or local ones, where they don't have purulent complications at all. Of course, it is omnipresent. And of course, we are doing a number of prevention measures to avoid that. To some extent, we are lucky, since in the structure of our institute, that is part of University Hospital, we have a purulent surgery and osteology department. So in Russia, We already have a specific purulent surgery department where we can hospitalize those patients. And of course, it's not just for patients who have the spondylitis, for example, but for those who need urgent surgical assistance. All the other patients get conservative treatment, or if we are speaking about our region, they are in city hospitals, and we may provide some remote consultations, and especially if we are talking about other regions of our country. But overall scheme of treatment is the same. It is a long-term antibacterial treatment. Part of it takes place in hospital, and then patient gets some out-of-patient treatment. Unfortunately, we see a lot of patients who come to doctors too late, where there are already some complications, or when there is already a resistant form if the antibiotics were not well prescribed. And in that case, there are some complications, including complications of antibiotics. And in those cases, we may face very severe complications such as sepsis. So it's a difficult question. In this purulent department that you have patients with different pathology, right? There are patients from general surgery, traumatology. We have there are patients with periblunt or periprothesis infection. We have there patients with some other complications, for example, post-surgical infections. These patients go there, or in case of osteomyelitis. Thank you. I'm going to try to be brief and share my philosophical approach towards private surgery. I'm now speaking about surgery of the patient with spine conditions. I'm head of a federal medical university. Perhaps I will be a bit subjective, but still I would like to share it. I would also like to thank Greg and Mark. Together with Greg, I have been doing research for a number of years, and also we've had observed fellowship. I went to Greg's clinics, and of course I was able to witness how healthcare is organized in the US and how patients with spine conditions and pathologies are treated. Of course, there is a huge difference between the US and Russia in that respect. At the same time, the US system also has some shortcomings. Sometimes it is even broadcasted by media. And I am now going to speak not about Russia only, but about trends in general. Now we witness the change in treatment paradigm. The care provided should be efficient, cost-saving, safe, and patient-focused. To match all these four criteria within one hospital and achieve very good results, even in the United States, a lot of effort is required. It is quite difficult, and all of that means that even such a developed state as the United States has issues regarding organization. If we go back to this country, of course, our situation is even more challenging because, in particular, we have different economic conditions. Spine surgery is today one of the most technological, scientific, and costly, as was shown yesterday by Dmitry during the presentation and in the evening. We saw the surgery departments, and it is easy to imagine how costly it is to organize such a hospital, even in Moscow. Now, you know that we have been speaking about evidence-based medicine a lot, and we are working within the framework of evidence-based medicine. We have guidelines that we follow, and now it turns out that even traditional randomized clinical studies cannot objectively evaluate the rapidly developing treatment technologies. So any randomized study is costly. It requires time. It requires going through various agencies and instances, and in addition, the population of patients is very heterogeneous. It is always changing. We have new professions. All professions are disappearing. People are more mobile, and this also impacts the structure of morbidity. And finally, we are now accumulating big data. In some countries, there are registries organized based on this, and these big databases today allow us to quickly compare the efficiency of various treatment methods and allow us to make forecasting and simulations. As a doctor, I meet patients every day, and sometimes patients are asking me, Doctor, how often do your patients have complications due to surgeries? How often nerves are damaged? How often there is liquor, and so on? This is a normal question of a normal patient, but still many doctors are discussing such patients and are saying, oh, I've received today a patient who was too smart. He has been reading too much online. But actually, I believe that it is normal, and that's how a patient should be like. At Greg's and Mark's hospitals, usually patient is accompanied by another one or two people who are asking those questions, and the doctor should answer these questions honestly. But if we say that there is a complication in 10 to 30%, it sounds like something too general. So today, based on big data and big databases, we can make a quick forecast simulation for a particular patient. We already have some forecasting calculators. So in real time, you can introduce the patient's risk factors, and we will see that for him the complication risk is 5%, and for another patient it will be 25 or 30%. So that's the difference. Sometimes patients come and tell the doctor, you know, my neighbor got a surgery in your hospital and he got complications. In that case, you will have to explain the patient that his neighbor is different. He also has a disc hernia, but his disease is very different from yours. If we receive an elderly patient, he usually says that he has pains in the back and in legs, especially in case of degenerative disease. His quality of life is decreasing. And while patient is telling that, doctor thinks, what is the clinical significance of this, and what surgical technology to use, because he has to take into account the cost of treatment, especially on the private market. He also needs to take into account the lack of consensus and the variability of solutions in surgery. And he has to take into account the developing market of minimally invasive technologies. And we know that there are a lot of tech companies who suggest doctors to be the first in using these new technologies. But what are the results of such treatment? So far, unfortunately, there have been No, there hasn't been a lot of research in that area. Over the last few dozens of years, we witnessed a huge increase in out-of-patient surgery. Unfortunately, I only have data for the US, but in the US, over the last 10 years, there is 60% more outpatient surgery rooms. The surgeries of degenerative stenosis increased by 2,000% from 1994 to 2006 in the US, and the surgeries of disc hernias increased by 340%. Unfortunately, Russia doesn't have these data. So, what are the advantages and disadvantages of private surgical clinics? First of all, I'd like to highlight that although I am head of a state institution, I am a proponent of private clinics because it's about business. Greg mentioned business. When we say that the doctor is doing business, I believe that it is good. If the doctor is doing business not related to medicine, perhaps that's not so well. But if doctor is doing business in medicine, that is good because it allows to optimize costs, optimize efficiency, performance through narrow specialization, through additional motivation of personnel, and through perhaps some other advantages. I don't know what they can be since I'm not working in private medicine. What are the disadvantages? In Russia, it is the limited spectrum of interventions, mostly with MIS technologies. Of course, doctors all around Earth are using the principles of not harming. Another disadvantage is a limited opportunity of collecting data regarding quality and safety of the methods of treatment used. Not all the doctors in private clinics are going to trace the results of their surgery. And anyway, there is a high risk of recurrent surgeries after spondylolisthesis. This is something that was proven in an international study. If we are speaking about out-of-patient surgeries on the private market, complications occur more often. Regarding the amount of surgical care in private clinics, as far as I know, in Russia, we are not yet working with generative lesions of neck or MIS fusion. In Russia, these surgeries are not performed in private clinics, in contrast to the other countries, because such patients need constant supervision, and it is quite difficult to do this. At the same time, in state surgery clinics, there are also quite a lot of disadvantages. Any public hospital is going to work with a patient that it received. Of course, it would be nice to treat only those patients whom we like and the pathology that we master best. But unfortunately, we have to treat all the patients who come to us. So we cannot use only MIS technologies, for example. Speaking about my institute, per 6 doctors, we have 1,700 surgeries per year, and only 10% of them are minor microinvasive surgeries. So we have a huge number of large surgeries, and when the doctor spends 12 hours, 4 days per week in the surgery room, the matter of burnout becomes very relevant. In 5 years, any doctor, even the coolest one, starts making mistakes more often because he is tired. And in our big institution, we have 9 departments. We have a purulent department, oncological, neurosurgical department, orthopedic departments, and all of that in old premises. So the epidemiological situation is quite challenging, and for the epidemiologist it's difficult to control the situation to avoid hospital infections. Advantages include multidisciplinary and comprehensive approach, of course. Then, such big state hospitals provide a wide variety of implants, surgical technologies, additional equipment. Fortunately, this is provided by the state. There is also a high amount of surgical work. So that's a possibility for surgeons to develop their skills. There is also a higher level of safety for elderly patients and the possibility of deep analysis of long-term results. Here you can see an American study where a group of authors did a retrospective analysis of 4 groups of patients serviced by a multidisciplinary team in a specialized department. And the average length of treatment, even in severe cases, was reduced quite significantly. Although later they said that it did not have a big statistical significance. There are various kinds of spine deformations, and in the federal institution we can resolve this issue in various ways. We can do micro-invasive surgeries using micro-accesses, frontal ones, back ones, combined ones. We can use those methods to resolve those issues and let such patients go quickly. And for us it is today 4 or 5 days in hospital. At the same time, there are more complex lesions when patients have musculoskeletal system impairments, and of course this patient will spend 14 or 10 days in hospital and maybe a blood transfusion will be required.
And these patients should, of course, have surgeries in public hospitals. Also, we have a lot of patients after private hospitals. When you already see the patient who already had 2 surgeries, and he again comes to the private, hospital, and they say to them, you should try once again for the 3rd time to remove the disc hernia, and so then he comes to us, and we can see that so we should perform quite a thorough surgery. Patient does not need any implants in this situation, and it's good. It's very good. It's great that these patients did not go to the private hospital for the 3rd time, because in the private hospital they put implants like this. You can see this in the picture. And of course, we have to redo all this in our hospital. I don't want to focus on this. In private hospitals, not everything's so bad. But conclusions. But we need to have spinal surgery in a very separate specialization. There should be a surgeon, who should be busy with spine surgeries, and in this case he can work in private hospitals and also in public. It doesn't matter for him anymore. So also we need to evaluate the results, outcomes of treatment of patients, irrespective whether this hospital public or private, out of patient, and practice should be developed in this area, but it should be also fully integrated in the professional community, and also we should use evidence medicine. Thank you very much for your attention. Thank you very much. Do you have questions to our speaker, maybe comments? We don't have so much time. I have a lot of questions, but especially the last slide I liked very much, but we don't have much time. Even I had a thought to show this slide at the Ministry of Healthcare. Alexander Gubin is pragmatic. He looks very intelligent and kind, but still he's tough, as I understand it, and he manages efficiently. So he combines all this also with such properties. He wants to create customer-friendly hospital. Is it possible? 10 years ago, I was thinking that the most difficult part of traumatology and orthopedy, this is spinal area. But now I understand that the most difficult is organization of healthcare system, because there nothing is apparent, nothing is understandable. First of all, we understand that we as if we live in different epochs. On the one hand, we have the epoch of our Soviet time. But still, this is Moscow. This is not Kurgan city. This is the market, and we are working at the market. We have one surgery after another. We have a big flow. We are Russian. We are always in a hurry. But our patients live already in virtual reality, as we understood this yesterday. They understand what to do. They read a lot of internet. They explain to you even better than you explain to them. Maybe they will replace algorithms themselves soon. And patients, as it was earlier, know very well how to cope with their pathologies themselves, or some other patients can help them, and not obligatory physicians. Very often paramedics are more efficient with these patients. And the main thing, there is also family, relatives. When we try to understand this in our clinic, we always have brainstorming, what should we do in the future. We discuss our strategy, not even tactics, but strategy, and then we discuss it. So we understand that we have risk groups. Do you know who is the most risky? Not patient. Patient comes to a bed, he's here, especially at the federal hospital. He has quota and so on. He has disease, but he has relatives, and relatives are never predictable. You don't know these people. You don't know how it will influence on you, on your reputation. And as the administrator, you feel this, and always, every day, many times per day. What is this clinic friendly for customer? We apply this term, but we did not invent this. So patient-friendly hospital, this is a widely spread European term which defines a hospital with special good conditions for patients. In the USA, this is the family-oriented hospital. In Brazil, it is called they have the program since 90s, humanization of healthcare system. They call this like it in Brazil. I think in Russia people will not accept it, this humanization of healthcare system. But we have to do this. But we choose another term, customer-friendly hospital. We have been doing this for many years. We have been doing this with our nurses. You know, physicians work badly in this area, but nurses work much better. Practically all practices, brainstorming we conduct with nurses, chief nurses. Sometimes even guards, security guards help us, you know, healthcare professionals, all healthcare professionals are involved. So we have this definition. This is the system to have good cooperation, interaction between employees, to minimize psychological, physical sufferings of both sides during the treatment, both sides. It means that you fail to make the system good for your employees. Employees are not only physicians, maybe administrators also, maybe security guards. If you don't do audits of this organization, if it's not good, so you can't also work with patients. You can't love everybody if you don't love yourself, and that's clear for everybody. Now there are many approaches. So we have a directive approach in the healthcare system. They say to us we should launch new mechanisms. It's a Japanese system. WISE hospital, it's called. So you can have directives, instructions, but directives you work very badly. Lean. But because the all principles of friendly environment is in conflict with the system, how can we differentiate patient-oriented and customer-oriented? This is close. When you have a patient-oriented system, you you don't give not necessary manipulations to patients, but customer-oriented means that patient should have a lot of different services, and the more services that he has, the more expensive the services are. That's the better for customer-oriented system. There is no conflict, but patient-oriented, this is a high level of the strategy. It comes from the government, but customer-oriented, this is a tactic situation, how to work in quite narrow department. There is no conflict, but you should not confuse these terms, these understandings. So now let's go to the practice. We invented such a thing which we called PAX, the principle of PAX. And the first program, this is acceptance that the problem of humanization exists, or humanization. People should understand this is really very important. And secondly, a constant audit of the processes, because you know, everything changes very quickly. So you should update everything quickly. Communication, and then the last one, this is the means. The key value also in our hospital to cherish values. Here you can see our patient is our partner, and we have values. So with all our team, during many years, we were developing these values step by step. Not everybody agrees with this. There are different models. Our value in our center of Yelizarov it was quite difficult to be accepted. But this is also our mission and value. And in each department has the mission at our hospital. And then the team also is making a decision. So not only to fulfill standards, but do something more essential. So audit, this is just an example of audit. You have a problem with something, so maybe remove some paper out of circulation. This is an interesting audit, risk audit. We have conducted this at our place. We split risks into paramedical and medical. We formalize these risks. We have brainstorming. And then I did not show this to you because this is closed information, but we encode them. We can see here we have encoding. You should be careful. Do you understand what I mean? Also, next thing is communication. That's the next item. So how should we name people? Oh, in Russia, we don't have. We don't know how to apply to people. We all want everybody to pronounce our name and patronymic name. But again, we have conducted survey. What terms do we use? How do we apply to people? For example, so-called Tovarish or mate, it's quite difficult. Mister also is not good in Russia because. So the old also terms patient, no, and ill person, of course, no. We can, you know, say just a young person, man. You know, Sometimes we can speak about a patient like this is old guy, and maybe this old guy doesn't like when we name him old guy or old lady. So this is called, or we can say just A in Russian. So we have this problem, and in the State Duma, we should have the position how to name these people, because earlier it was tovarish, so in the Soviet Union, like for everybody, and that's very difficult. Or just, hey, how can we call people? But these are conflicts. This is really extremely important. We have one security guard. When he is on duty, we gave him the premium, even the bonuses. When he is on duty, we don't have any conflicts. 90% of our work, this is a conflict solution. These are not medical. Medical part is small. We always have conflicts, always have some fightings. And when the security guard is on duty, no conflicts, because he never says, hey, he finds approaches to any patients. He also worked as an administrator. He always, he's quite a talented guy, and he's a security guard. Now, again, another example, quite a fresh one. I have also on the site, I have the section complaints to directors, to director. So, and all complaints can be gathered in this section. And patient, give me a lot of complaints. For example, a patient wants to go through treatment, but he is religious. He says, I'm ready to be treated, but you have to do this. But this treatment should not be accompanied by any electronic wires, electronic, devices. He doesn't want this. No data submission to the insurance company. He found a bunch of laws, and so without computers, without data transfer. So, and this patient insists on this. This is one example, and there are some other examples regarding, for example, blood issue and so on. And there are laws. Sometimes laws help us, sometimes they don't help us. That's why we need this project approach. We should create a precedent in each situation, and then we create some certain work algorithm. And the most primitive one, this is called available environment. This is the means. This is a tool. You understand that you need an audit. Then you understand how to explain this to everybody. You have communication. Now you understand that you need a tool to do this and that. Or you can come to a very good hospital, reach. Sometimes I go to Siberia. I also go and do audits. A huge hospital, very nice, well equipped. They have money. So then I go to some place, and there is the tablet for blind people, so a traumatological patient tries to find this, to find this plate for blind people. So I think that's quite funny. They should not need this. Things. That's all. I think PACS system helps us a lot, and please, you can use, all of you can use it. Do you have any questions regarding PACS? So many. Yes, there are many names, and really we don't know how to apply to a person. So, hey, this is at the first place, maybe. Hey, guy, or how? Or how can we call a person? So, what do you recommend? How can we call a patient? Or maybe you have something. as a reserve for your center? This is quite a difficult question. We conducted surveys. Patients want to be named using their name and their patronymic name. And we decided to introduce a badge system not only for personnel but also for patients. Because we have many patients, and patients don't want to be, identified. They don't like badges, for example, they can violate something, and then everybody can see that this particular person did this violation. So they don't like it. They don't like badges, but they want to hear their name and patronymic name. I think it's better, maybe, to use the official name, Mr. But and maybe name and patronymic name. But also we have some speech methods how to communicate with patients. We have phone, we have business module, we have also emergency module, and when a patient come to us and also with relatives and they try to find some information, there is also a separate module, speech module. So different types of speech modules, but we have a lot of trainings dedicated to this. Thank you very much. So Mark, what about your speech modules? I think you also has the module how to communicate with patients, how to communicate with friends, non-friends, and also maybe he knows about some modules how to communicate with in New York. So Mark, we have one more physician, and he has had a long journey of becoming a good specialist. We sometimes we hear this American dream also in movies. It means that you start from the scratch and then you achieve a lot of things. I think Mark, we can say about Mark that he's an example of an American dream. But at the same time, I want to say the same as with Dr. Tkachov. He takes away our patients from us. He works with Herpia. So Mark, you all also take away some of our patients. But let's first listen to Mark, and then maybe it will be very helpful to us. Thank you, Dmitry.
My presence here was possible thanks to the fact that the moderator of our session, Dmitry Tukayev, is a well-established doctor with a very good reputation, but still he goes ahead, and I really believe in his ideas of helping patients. So all the innovations that are currently available in the medical world are focused on improving the treatment process for the patient and relieving the patient's problems, and he's trying to implement all that. That is why I am present here today on this particular session and not on the session dedicated to pain treatment. And I called my presentation Enemies or Friends. Why? Because apparently those who treat pain syndrome professionally, in particular pain syndrome related to spine and skeletal system, may apparently compete with experts who do surgeries. And it may seem that we are competitors, we are taking patients from each other, but actually it is not like that, and I will show and prove it. So, a couple of figures. Today one of the biggest issues of the civilization is low back pain. After 5 years old, more than 80% of the population will complain about back pain at least once. I've read a lot of statistics, and I can say that today in the world, $240 billion per year are spent to treat this kind of pain. And the current budget of Russia is $233 billion. So actually, the whole Russian budget could be spent on trying to cure low back pain and back pain in general. The goal of doctors is to reduce the time of treatment, reduce the pain, save costs, and from the economic point of view, that would allow these patients to get back to their lives and activities. Today in medicine, the goal is to minimize invasiveness, use conservative treatment, minimize surgery components, and alleviate the consequences of surgeries. At some point I worked as an anesthesiologist in the cardiovascular unit, and sometimes people asked me, what can a patient feel if he has an open heart surgery? And I compared that to being run down by a truck. So our goal is to minimize pain during the treatment, make the treatment period as short as possible, and cut the costs. I chose several examples where we can be useful. First of all, in case a patient suffers from pain but doesn't have any indications for a surgery. It may be a person who can be a good candidate for a surgery, but for some reason he is not ready to be operated. He might have some financial engagements or work engagements. He cannot stop working, he has to continue working to support his family, and so on. The third patient that we can help to is a patient who has had surgery but is still in pain. The next candidate is surgical candidate, but no one wants to deal with this case because the case is too complicated. And the last point that I added quite recently that started to emerge over the last 10 years, although today we don't yet have any scientific evidence for that. I'm referring to a case when surgeons refer patients to us so that we can make our manipulations and predict the result of surgical treatment. By our manipulations, I mean blocking. I would like to give you the example of some cases and highlight that we treat our patients not as clients but our patients. I say usually that clients go to restaurants and we have patients, and in a medical institution there can be no clients and no medical services. This phrase, medical service, costs a certain amount, is something that I find not very appropriate. So the first case is a patient of 41 years of age. He has numbness in the leg for 1.5 years. and pains. On an MRI, he has no changes. We made the blockade, and basically there is nothing to operate there, but still his leg was in pain. The second patient is a 72-year-old patient. He is a Russian administration member, and he has lower back pains for many years, but his schedule is very busy. Physically he is active, he is skiing. He cannot make the surgery that he needs, because after that he will not be able to ski for 1 year. And we had a 32-year-old patient that has already had 3 surgeries. She still is in pain. And another case is a man of a woman of 63 years of age who could not walk, and over the last 3 years she has been twice in our hospital. She was accompanied by her daughter and 2 men, and they were assisting her and everything, so she was not able to walk. And she is also head of a pastry and bakery shop, and she always brought a lot of pastries when she came to the hospital. So this is the picture of the first patient. We make a blockade, and his condition improved, and he did not return. I'd like to make a comment to my colleagues. Usually after the procedure we make a call to the patient, because we want to know how patient feels, and also for us it's about education. Because if we don't get feedback from the patient, we don't know that our blocking helped or not. So we always call the patients and we record this information to be able to learn whether we did everything correctly. This is the patient's image. He received 2 blockings. The first one was medium branch blocking. It helped him for 2 months. After that we made a radiofrequency ablation, and he's fine for 1 year so far. This is a very interesting patient, the patient of one of my colleagues. She was operated 3 times. First of all, a herniated disc was cured. From the point of view of surgery, laminotomy was done very well, and that made my task easier, because when we did the blocking it was difficult to understand where to do this. After the first blocking she was fine for 3 months, but then we had to repeat it, and we administered another medicine. And for 6 months she has been fine, and we actually even didn't manage to reach her by phone. Severe cases are of course difficult to treat, so here is the patient, the last patient I was talking about. She weighs more than 300 pounds, and she required assistance even to move from the wheelchair to the bed. And we made her a blocking, and for 1.5 years she has been fine. Of course, no one wants to make a surgery to such a patient, that is clear. So we are here to help you. We have one common goal of helping our patients. So are we friends or enemies? Of course we are friends. Thank you.
с ним лучше дружить.
Yes, it's better to be friends with him. A very important criterion today that I understand is that if you call the patient after the surgery and he doesn't respond, everything is fine. This is Mark's criterion. What else can we think about if the patient doesn't respond when we call him after the surgery? Well, let us be optimistic. Are there any questions regarding other criteria? Well, we tried to make our session and our communication efficient so that we could understand better what is happening with spine pathology and treatment today. We considered various approaches. We see that there are a lot of medical professionals treating spine. If you Google spine treatment, you will probably get a huge number of responses, and there will be a lot of offers on behalf of medical centers. This is a very widespread condition, as widespread as alcohol issues and some other issues. So, yes, the issue is widespread, and we need to be friends in this huge world. Our dream is to create a hospital friendly to patients, or create a medical environment that would also be friendly to all the stakeholders. This is something that could be discussed next time. So we should be friendly not only towards the patients, but also towards each other. I would like to ask Alexander to make his choice. Have you identified the one to whom you would like to offer your books? I feel that the doctor behind you, who came from Volgograd, I know that he has dreamt of working in a foreign hospital. He has been searching happiness, and he came back today to listen to us. You know, first of all, I wanted to give the book as a gift to Alexander, because this socialism with a human face is something very unusual, and focus on the clients is very important. I think that that was a very interesting presentation, but let us give it a round of applause. I completely agree that we have to interact with our patients, but he is going to bring this book to his security officer. Well, probably yes. I have 3 copies of the book. Overall, 2 of them are at home, and I would be happy to give those copies to the people who are interested in that. Raise your hands, please. So, I have 3 copies of the book, and next time when I come to Moscow again, I will be happy to bring more copies. Are you also going to read them? So I will bring more copies next time, because the knowledge is something to be spread, and I think this is part of the friendly approach. So there is a whole fight for those book copies. I have 2 left. I think that it makes sense to give this copy to colleagues who came from other cities like Krasnodar or Volgograd. They came here on Saturday, although they could have gone to a cinema, for example, but they are here today, and I completely approve of your choice. And of course, this is necessary for those who are interested in that. Thank you. Thank you all. Thank you, everyone, and see you.